flown for this purpose only to be at this conference. And I am moved and I'm humbled, and I'm deeply grateful for that effort on his part. He is a visiting professor in at the Psychoanalytic Unit at the University College of London. He is a visiting consultant for the Menninger Clinic, and he has written extensively on mentalization, and I will introduce him a little bit more when his turn comes to give his part. But for now, I thought I'd give an introduction before he started the panel. All right. I would like to start the ball rolling by asking all three of you, what progress and developments do you see in the next few years in the treatment of borderline personality disorder, both in terms of causation, in terms of treatment, in terms of policy making? What would you like to see happen in this area? Anyone can begin.
You haven't spoken yet.
Let Anthony take it. That's a tough one.
It's like the
Good question.
The three monkeys. I'm going to anyway. It is a tough question, just about how things will go. I mean, for me, there are a number of areas I would really like to see develop over time. And one is that our understanding of the development of the disorder of borderline personality disorder, I hope that that will increase. It's increased dramatically over the last decade, I think. And that if we're able to begin to understand the development better, we will then be able to implement prevention strategies in some way. So I'm pretty keen that we continue to consider the etiology and begin to develop prevention strategies if we can. And that's likely to mean interventions in early childhood and in adolescence, certainly, which I think we neglect at the present time. So that's certainly one area I'd like to see develop. Another area that I think will be important is that, as Glenn outlined, we've now a number of treatments which appear to have reasonable effectiveness. And although there possibly are some differences in treatments, I could comment on that for a long, long time, because I think the differences are much smaller than some of the treatment adherents, like myself, for example, would wish to maintain. But nevertheless, I still think we need to work out what the effective components of treatment are, because it's clear that we've got these relatively complex treatments in many ways, but actually they're probably more complex than is required, and we don't know what the effective elements actually are. And if we could begin to tease that out, we may be able to develop even more effective treatments. And finally, I'll just say that within that, all treatments that we have at the moment are probably only benefit certain groups of patients with borderline personality disorder, and not all. It's not one treatment fits all patients with borderline personality disorder. And we really begin to need more understanding of who benefits from what and why they benefit from that or may not. So I'd really like to see work done on that over the next 5 years. And if I could also make a plea, which we have in the UK, that availability of treatments, the ones we have even, is something that government, public health people and so on have to take seriously. We've persuaded the UK government to take it reasonably seriously, although, as you know, as I mentioned to someone yesterday, the problem with governments is they're fickle. Not just they change, but their priorities change overnight, and you were for a moment the flavour of the evening, and then tomorrow they've forgotten all about you and forgotten that they said they'd give you X amount of money and so on. They've moved on, so you have to grab it when it's there. So anyway, that's enough from me, I think.
I really agree with the points that Anthony made. One small thing I just wanted to add. I mentioned to you guys earlier that when we were lobbying in Washington, the only thing that was of interest is, could you save money? But there's another element I left out, which you just reminded me of. In Congress, the only thing they're interested in is the budget year. So if things don't show changes within 1 year, they weren't very interested. You'd have to make a very strong case to say it makes sense to think beyond one budget year. And you saw the slides. Usually it takes 12 months to get results. So that's another problem in getting the funding. I just add to what Anthony said. Remember that slide about how the orbitofrontal cortex was in some way enhanced by a specific drug, an SSRI. I think in the same way we want specificity more with the therapies and who benefits the most from a particular type of therapy, we would like to do that with medications. And we've got a lot of neuroimaging studies going where we may be able to target certain areas of the brain with the specific agent that works.
I just very much endorse what Anthony said, and also Glenn. I think while we're in the process of doing the best job we can to redefine the personality disorders, put them in the right place in the book, describe them the best way we can, what's happening in the field is a very interesting and a quite exciting movement, which is the neuroscience frontier, and it's zeroing in on treatment planning at the individual patient basis, which is quite interesting because we've been in a different world, and still are, and will be for some time, which is to try to do the best grouping we can of types of patients and then study that diagnostic group. But I had the meeting not long ago that the National Institute of Mental Health holds once a year to talk about psychotherapy research, and I was asked to go as a representative of the American Psychoanalytic Association. And there's some really interesting studies. So, for example, there's some NIMH-funded studies being carried out by a researcher at Emory University, Helen Mayberg. And she's mostly looking at patients with depression, but these principles apply in lots of areas. And she's studying things called neural networks, which Glenn talked about. But you can, through brain imaging, and most of this is PET work, you can identify, and she's published some of these data, different neural network patterns. And she's got one study that is so interesting that looks at, remember that slide set I showed you, the subtraction study comparing psychotherapy, cognitive behavior with citalopram in the study of an anxiety disorder. Well, she's got one study that looks at a pattern of neural network imaging that represents patients who are preferentially responsive to medication. A different pattern that represents patients who are preferentially responsive to psychotherapy. And a third pattern which represents patients who don't respond to either. Or we've got to figure something else out. And Tom Insel, who's director of NIMH, made a very interesting comment. He said, it's really interesting that we at NIMH are coming around to the position where you, the psychoanalytic world, have been for a long time. Because you were always saying, we need to look at the individual patient, not just big diagnostic groups that are in efficacy studies that don't really correspond with real life. But that's where we're going. So I think that's exciting, and I think that's the ambitious sort of future answer that we can be very hopeful about.
We have many questions on treatment. I want to ask a quick one, Dr. Oldham. Will you give us more information on the personality self-patient graph? In other words, where we can get it and who developed it?
Oh, sure. That's actually something that I developed with my co-author, Lois Morris. Thank you for the question. It's the current version of the book. It's a paperback book that's published by Bantam, and it's called The New Personality Self-Portrait by me and Lois Morris. and has a self-assessment test in it that produces the graph, tells you how to score it, and people actually have a lot of fun with it. I would just say one other thing. What we did was an effort, and I guess its long shelf life is perhaps a reflection that it was successful, was to try to detoxify the whole notion of, and depathologize the notion of personality pathology, and talk about the range of different types of personalities and styles, and that we've all got rough edges, and we have recommendations about how to work on, and sort of the underlying messages that you can change. And you don't have to just sort of figure out that it's never going to be any different. So thank you for that.
Another question is, if there are 256 combinations of borderline personality disorder criteria, how far are we away from saying that DBT is better for this cluster of criteria, or TFT is better for another cluster of criteria?
I'll start, but I think others than Glenn and Anthony may want to talk to that. You know, one of the challenges that we've got, if we go to DSM-5, so I talked a little bit about the threshold problem. Okay, let's take DBT. We've got 9 criteria. We've got 5 out of 9 that you need, any 5. Well, that's called a cut point. So you say that you got to have enough of what we have on the list for us to decide we're going to call it a disorder. But obviously, there's no magic to the fact that hypertension is above 120 systolic pressure. It correlates with sort of clinical wisdom. If we go to a dimensional system, we're still going to have a threshold to say whatever we're measuring, if it's novelty seeking, if it's some other kind of behavior, there's got to be a point where you draw the line and say, okay, above this much, we're going to say that's probably trouble, and it's going to interfere with functioning, and it's going to be what we'll call pathology. So I don't think we're ever going to get out of this need to approximate how we define what the problem is. I do think that we've got a much bigger universe of variability in our definition now, and that even if we do just the little thing we were talking about, which is getting the symptoms out and differentiating them from stable traits, that will make the way we're defining patients in this category a little less heterogeneous and a little less sort of variable. And I think that will help.
Well, I can add very briefly. One interesting fact is, I think, is the Norwegians that both the speakers mentioned are avoidant enough to spend a lot of time trying to work out how many ways there are to diagnose borderline personality disorder, and actually they disagree with the figure of 252 or whatever it is, and they think it's over 340. I suspect they're right, by the way, because they spend a lot longer in their avoidant state obsessing about such things. So there are many ways. But the question about how close are we to looking at those patients who have certain patterns of diagnosis, respond to certain treatments. I mean, to be honest, I think we're miles and miles away from that. We're just nothing like there at all. And I can't even see that we're likely to get there very soon at all with the level of data that we actually have, I'm afraid.
Now, there's a very practical answer to the question, too, and that is that most psychotherapists, when they're working with a borderline patient, are not fanatical adherents to one particular approach. Most of us shift a little bit, try a little of this, a little of that. I found some borderline patients could never use transference-focused therapy, that they cannot work in the transference chip, so I stay out of it. And there are other patients who work very well in it, and I'm always adjusting the way that I approach the patient based on a kind of trial and error, so that practically speaking, we adjust quite a bit and give a little bit of this and a little bit of that to many patients.
And I would add, we try our best to capture the magic bullet. What is really going to be what makes the difference? But our patients are very different, and everyone needs that kind of flexibility. And I very much agree with that. I think that you have to be very responsive. If you read Gunderson's book, he will talk about, session to session. You try to date the patients in at that time, which determines what effectiveness you're going to have and how you're responding. But I think that we have to be very, very open to that kind of flexibility as we work with.
Do you have a formal modality of treatment in the process, changing from DDT to TFP or to SFT? Do we have any way of identifying that?
Well, it's kind of early, but I've certainly done that as a consultant on cases. I suggest someone move to DBT instead of trying transference-focused therapy, or move to mentalization-based. That's sometimes a good thing to bring a consultant in for, to find out should there be a shift in the type of therapy.
We have several questions on adolescence. I'm going to use the first one as a kind of a impetus to lead to the next one. And it's a general question, and it is for all of you. Could you speak to the current state of knowledge on borderline personality disorder and borderline personality traits in adolescence?
Again, I can just say a quick word about that. The diagnostic manual, again, one of those decisions which was pragmatic more than evidence-based, set the age requirement to make the diagnosis at age 18 for the personality disorders, and that really is arbitrary. And actually, just there's a lot of evidence that is just a convention that was adopted. But if you're going to become borderline, it doesn't all of a sudden happen when you turn 18, or it doesn't happen later in life. You will see a continuous evolution or development of the behavior. Sometimes it is frequently it's very hard to predict. You'll see an assortment of all kinds of early behavior. It can be oppositional, it can be disruptive, it can be thought to be ADHD, it can be thought to be some kind of even childhood bipolar disorder, which can sometimes look very similar. Rex Cowdery had written about that some time back. And there are people who are looking at this. Pat Cohen's group in Columbia has been looking at a very interesting cohort of patients, and they started following these patients when they were about, you remember, Glenn? Or Anthony, I think it was about 13.
Yeah, a bit before that, I think.
No, maybe it was earlier, maybe 7 or 8. Age 7 or 8. And they've followed them now until they're in their mid-30s now, and have some very interesting longitudinal real data that enable them to track what those early patterns looked like. The late Paulina Kernberg has been very interested in this area, and others also. Efraim Bleiberg at Menninger Clinic has written about what he calls emerging personality disorders, and has a book by that name looking at the early patterns that begin to develop. So I think that in even pre-teen years you begin to see that. It's always easier to see retrospectively than prospectively, and that's part of the challenge.
I mean, I think this is a terribly interesting subject overall, and I think that we're only just getting knowledge about it. But if I can just go back slightly, because I'm quite interested that John's talking about cut-off points and so on, and how they're arbitrary and so on. But you do use the, if I can be slightly provocative, the sort of comparison with something like hypertension and so on. But we do know that the reason we have cut-off points in that above that becomes highly toxic to the individual. We know the outcomes get worse and so on. And the problem we have is we don't know these sort of longitudinal data really, really well, although there have been attempts to get this sort of data in personality disorder to define sort of cut-offs about how well or badly somebody might do naturally over time and things. And the same applies to 18 as being a cut-off. It becomes fairly arbitrary, as you say, I think. But there is now some evidence, particularly through adolescence, and you were mentioning Pat Cohen's studies and others, that I think it's beginning to be possible that if you look at adolescents who've got mostly behavioral conduct problems, actually they don't do so well. But those adolescents who've got sort of emotional ability type problems tend to improve. And so, they tend to sort of slightly divide out. And so that's one thing to think about if you're trying to make these diagnoses in adolescence. But the second thing is in the Cohen studies, which was brought up at the recent conference in The Hague on personality disorder, was that even if after the period of adolescence you no longer meet criteria for personality disorder, having met or been near criteria during this phase actually leads you to have lower social and interpersonal function later. So in other words, having that level of disturbance in adolescence retains a certain toxicity even in your 20s, which is a very interesting finding, I think, overall.
Here's an interesting question, and I think most of us can relate to this. How should family members deal with the borderline personality disorder patient's resistance to therapy and/or hospitalization, or perhaps insists on non-traditional or inappropriate or non-effective therapies?
This, of course, comes up all the time, and there isn't an easy answer to this. And some of us were talking during the break about this very thing. It's sometimes worse when you force a patient into therapy who doesn't want to be there, twist their arm and say, you have to do this, and then they often become very oppositional and say, I'll show you, I'll just not use the therapy, I'll not speak, I'll not attend or whatever. And it gets back to this issue of the therapeutic alliance. You have to have enough suffering. Something has to be bothering you enough to actually get, involved in a reflective process about what's happening. And sometimes the patient has to bottom out a bit, just like in the 12 steps lingo. They have to get enough suffering in their lives to be motivated. And it doesn't always happen. It sometimes works out that way. I think families often can benefit from meeting with a mental health professional who can help them think about, okay, how much do we put up with in terms of what we can tolerate? Where do we set limits? What's reasonable tolerance versus indulging the person? And these are very difficult questions that, again, have to be handled on the individual basis of looking at the whole family and the patient's characteristics. Would you say that?
I'd just add one thing. It's really tough, and Glenn and I and Anthony, and I'm sure many of you in the room have heard just heart-wrenching story after story about years and years of just enormous concern and struggling, and the patients themselves struggle with this. There is no easy answer to this. One question also came up at the discussion at the break, which was about a daughter who is in therapy that's lasted 1.5 years, and that's good, but where the therapist has been uneasy about using the term borderline. And should we or shouldn't we? I personally agree with John Gunderson and others that we should talk about it, or there may be exceptions, but that generally I think that's a better approach. And that psychoeducation is helpful. We shouldn't be afraid of a label. I know a lot of people have come to me and say, well, we should change the label because it's gotten a negative connotation. Well, it's not the label that's got a negative connotation. It's not understanding the patients. And many times, if the patient is not wanting to be or unable to own the problem, there's an externalization and a blaming process. It's your fault, not mine. But we need to understand that that's a function of distress, and the problem the person needs help with. So I think talking about it, I find actually one really easy way to do it is pick up on these endophenotypes. So I say, okay, one way to think about this is that this is a condition that is borderline because it's on the border of a mood disorder, and it's on the border of an impulse control disorder. It's on the border. It's not way over the border. It's not extreme, but it's got those problems, and that's what it means. And so let's talk about it. And that means you're struggling with keeping your impulses under control, not doing something that's self-destructive, And we understand more about that. So that's what the label means. Go read about it. For the families, I think, as Glenn was saying, families gathering together as groups or multifamily groups where you can share your experience but also get some advice can be extremely helpful. It doesn't mean you're necessarily going to go back and be able to do anything different than you're doing, but it can help you feel better and help you sort of keep it in context, and that's important.
I mean, I agree very much with Glenn. I mean, sometimes you have to, as it were, see the family who are more concerned and work with them to help them manage whatever is a very difficult situation. But I'll give you a little story. It's quite interesting because, you know, you get referred new patients all the time, and a patient comes. This young woman came in to see me. This was only 2-3 months ago. And I, in my sort of slightly lackadaisical way, said to her, well, you know, what's brought you along today? And she looked at me and said, my mother brought me in her car. I thought, oh dear. I thought, we've got a problem here. I could tell straight away, you know, I'm quite sensitive like that. I thought, this is a problem. So I said, you know, so I said, what did your mum bring you for? She said, so you can do the therapy, so I'm here to do it. But the point of my story is, of course, was then actually the whole question then was whether or not there was any ability for me to help this person shift at all about, you know, and so on. And eventually we agreed that it was someone else who needed the therapy, not her, was really the position we got to. But it took quite a long time to get there, which was one way out. But the serious point is actually one aspect to it is Glenn is emphasizing, is trying to, even within difficult circumstances, forge some little flicker of a therapeutic alliance with that person, even if they're negative, oppositional and so on, and things, you know, she said, well, what do you think's wrong with me? And I agree very much with you, John, that, you know, we can explain these things. I said, well, thus far, I said, it's oppositional defiant disorder until proven otherwise. You know, I haven't done anything except ask. And so I sort of challenged her a bit, but to try to forge some alliance so you can begin to work on the motivation, so you can begin to reduce the sort of sense that everybody sees them as the problem, you know, and these sorts of attitudes, and you're just going to be the same, or you're the agent of someone else to make them behave, you know, all this sort of thing, which is part of the skill, I think, in developing the treatments, and why the treatments have set up very much, very often, not just within an individual. They're working with teams, the teams support each other and so on to try to help with these sorts of difficulties.
I think this is a question for you, Glenn. Discuss transference-focused therapy and schema-focused therapy in more details. In other words, specific approaches used in each therapy.
You know, I think probably John or Anthony could do the schema focus better, because I believe at the Hague meeting that was presented, and maybe one of you could talk about that, but in the transference focused therapy, the idea is to identify certain characteristic patterns of self and other connections or object relationships that go on, and you can think of a triangle in 3 different domains. One leg of the triangle is the therapeutic relationship, the transference. The second leg of the triangle is current relationships outside of the therapy, and the third leg is the past relationships with parents, siblings, other people, and then peers in one's life. And then you try to look at characteristic fantasies about what the other person is up to and what you want, and what your desire is in the relationship and your fear in the relationships. And then you try to make linkages then between what's happening with you, that's the transference focus, and what's happening in the past and outside the therapy in the current situation. And as I mentioned, interpretation is a major intervention where you try to make something that's unconscious become conscious by pointing out a link they don't see, or an attitude towards you that they don't see. And when Anthony talks this afternoon, you'll see that transference is viewed differently in mentalization-based therapy. And my understanding in schema-focused therapy, you basically don't use the transference in the way that you do in transference-focused therapy. Now, John, you may wish to talk more about schema focus, since you just heard a presentation.
Well, or Anthony may. Actually, what was said earlier, I keep coming back to myself, which is I'm more impressed with the common elements of a lot of the therapies. But the presenter who was presenting schema-based therapy in The Hague itemized all the bullets, and if you took the title off, you might have trouble distinguishing it from DBT, because a lot of the elements were very, very similar. But in essence, it's one of a different set of treatments that focuses on cognitive belief systems that, of course, have longitudinal sort of durability, and they've been there for a long time and become sort of embedded as established fact. And so there are a set of schemas about who I am, how I'm seen in the world, how I interact with the world, what the world's like, what the people in the world are like, how they view me, and how they're going to react to me. And I believe that, and it's gospel, and it's automatic. And so the therapeutic effort is to first spell out what the beliefs are, and they'll be more prominent of different types of different patients, so you individualize it. And then once you've got that clear, and you do this with the patient, you then begin to say, okay, now let's think about this, and propose what-if hypotheses about ways that it could be challenged and different. And it's almost like we talked about earlier, what goes on in therapy as a form of learning and memory. And in all of these treatments is the fact that the person whose daughter was in treatment has been in treatment for 1.5 years was good news, because it's time that you need, and you've got to sort of be able to hang in there. And it may be that a particular approach is going to work better overall with one patient more than with another, or that your strategy will change as you go along. But most of you got to stay in the room together and get to a point where you begin to help. So it's almost like being in school in some ways. And in the schema-focused and cognitive approaches, there is a lot of explicit homework. Take this home, work on it, talk about it next time. And then so it is more directive, I guess, in that sense, that there will be a real focus on, okay, you didn't say anything about what you were supposed to do for today. Let's talk about that, and that will be a little more explicitly directive than TFP would be.
Yeah, I think that's right. The other thing, Jeffrey Young's written a manual on it, which is quite extensive. Having identified the specific schemas that are relevant to the individual, actually, but he does conclude that there are ones that are common to different personality disorders, and therefore there are some that are more specific to borderline personality disorder. There are then identified various modules, which are rather like skills modules, to really repair what they see, I think, as a sort of damaging system, which is activated in the schemas are activated in certain contexts. And one aspect I do think distinguishes it from other therapies to some degree is that, interestingly, it's a reparative therapy. They try to repair what they see as being damaged to some degree. So they have for example, one module is a reparenting module, where the parenting that went wrong is reparented, and so on. So that, I think, does distinguish it to some degree, because I'm not sure other therapies would try to suggest we were trying to do that sort of phenomenon.
Yeah, it's sort of in the direction of what used to be called corrective emotional experience, but elements of that, I think, are built in.
Another question is, why is group therapy, along with the one-to-one sessions, beneficial?
Well, that's a very interesting question. It's still a slightly empirical question, but in fact, in clinical experience, I think I agree with Glenn mentioned briefly that they probably do somewhat different things. And and they also may help prevent certain things. If we just take the prevention slightly, individual therapists can get in very cozy relationships with their individual patients, and the individual patient can get in a nice cozy relationship with their individual therapist, which in many ways is a very good thing. But there's nothing like a peer group to tell you where you're going wrong. And they can tell you a lot more bluntly, for example, than your individual therapist will do, because your individual therapist is benign, sensitive, nice person, and so on. And whereas your group says, that's a load of crap. But your individual therapist doesn't do that. Your individual therapist says something nice like, I'm just not so sure about that, or something, which is quite different. So it does give a whole different context, I think. Now, the other thing, though, of course, is that it allows all sorts of other processes that have been described, such as commonality, understanding other people who've got the same problems, finding out how they've worked on them, what they've done, and it's shared and so on, and you get good ideas from your own peer group and things. So it's terribly helpful like that. And finally, for us in mentalizing, it's a very powerful medium, but it's also therefore quite dangerous, because I'll discuss mentalizing after lunch, if we're all able to mentalize by then, but is that, at least think, is that in a group, of course, you have to begin to work out lots of different people's ways that their mind functions. Okay? In individual therapy, you can quite quickly understand how your therapist's mind functions. Therapists, after about 6 months, you know what they're going to say half the time. If I say this, he'll say that, kind of thing, all right? Now, we clever therapists shock our patients every so often, so they're not so sure. But very often, you begin to understand each other. You can get into systems that actually, where you don't learn a lot, you just know what the therapist, how they work, how they think, and so on. In a group, that actually doesn't occur, really. So, and then one final point, clinically, which I think is very good, we integrate the group and the individual. So the work you're doing, what I mean by that is the work you're doing in the group therapy is known to the individual therapist, and the work you're doing in the individual therapy is known to the group therapist. Now, we don't breach confidentialities, but it means that the individual therapist, if they know there's been some difficulty in the group, will say, hey, I know there's some problem in the group. What did you make of it now? Make them reflect about their behavior, what they've been saying, what's been happening. So we make them do things in a little bit of cold rather than in the heat of the group and things like that. So we link the two. So there are many other things about this issue, but it's a very interesting issue. Glenn,
really, Anthony summarized it beautifully. I just add one point to what he said, and that is people behave differently in groups than they do in one-to-one situations. And there are group forces that people get swept up in, and it's wonderful to be able to watch that and be able to comment on it with the patients and have the other patients comment, and they'll be very blunt, as Anthony said. And there's a corollary to that, too. You know how many teenagers will take advice much better from a neighbor or a teacher than they will from their parents? Similarly, in a group, the therapist becomes the parent in the transference, and they may not take advice from the therapist, but if one of the peers in the group says it, they'll say, oh, that's a good idea, I'll try that.
I would think also that the opposite is true, too, that sometimes boundary violations in groups need to be carefully watched, and the process of the group, if some self-defeating behavior is being introduced or as a new element to the person's experience, such as self-mutilation, that might be one thing to monitor in those situations. But I think the adaptive functions of the group far outweigh any problems that might be introduced. I have another question. Can DBT or transference-focused therapy be effective eventually for a patient who is in denial, has no insight, and is paranoid? Do I have any other bad prognostic features here to add?
Maybe the answer is no. One hopes. My best answer is your only hope is if you can have the patient in the room. And if you have the patient in the room, but the patient is denying, is paranoid, is oppositional, but stays in the room, there remains some hope. And you work toward it using all the principles that we're talking about. And eventually, sometimes that can help. I'll tell you just an example of that of a patient of mine who I don't think was a successful outcome, but I don't know that it was not helpful. This was a patient when I was a psychoanalytic candidate and my supervisor was Otto Kernberg. I had a patient I was seeing intensively in treatment who quickly developed a negative transference, was quickly attributing every problem she had in her life to me, and was just enraged at me every time she came in. I was just, and she was not shy in expressing this. So she would just say, "That is the most idiotic, asinine statement I've ever heard in my life. You have one or two pathetic ideas that rattle around in that empty head of yours, and I'm wasting my time being here." She was never late. She came religiously, and
Are you saying that with some counter-transference?
there may be an element there you can pick up. I was glad I had a supervisor like Kernberg who helped me keep my balance in this process. But this went in for almost a year. Toward the end of that, I began to make a little headway. So I was able to, using a typical clarification approach that's part of a transference-focused approach, I began to say, look, let's examine something here because there's a very strange contradiction here. Let's say you're right, absolutely right, that I am the biggest idiot on the face of the earth. How can we understand that you come here day after day regularly to waste your time with an idiot who's doing nothing but torture you? It doesn't make sense. But then let's say you're not right. And I'm not the guy who's the big problem. And that all of this rage that you feel you're justified in feeling against me because I'm so inept doesn't have anything to do with me. Well, there's only one other person in the room. And so could it be that this is something you can't tolerate, finding in yourself? So that's an example of the approach that you try to work on. She ultimately couldn't tolerate the long first vacation break, decided to move to actually a different state. And then she telephoned me for months and months, on which she would say, I made a terrible mistake, the worst mistake of my life. You were the only person who ever understood me. I blew it. I threw it down the drain. I'm seeing some guy here. He's just an idiot. He's a jerk. So eventually I had to say, look, I'm going to have to tell you that at such and such a point, I'm not going to take your phone calls anymore because I can't help you. You've got to work it out with the person you're seeing there, just like we were trying to do when you were seeing me. Now, eventually, I hope all of that got her to a better place. I don't know that it did. So sometimes you do the best you can, and you hope you get little inches of progress. And over time, I think that does happen.
But that leads me to kind of expand the question a little bit more. Does our own, as clinicians, is our perception of a dismal prognosis, our own countertransitive issues, how can we reconsider these when we attempt to address the need in our population? Or what do we need to do to make ourselves more ready to treat and to handle those with borderline in a more compassionate sense? And is there information? Are there strategies that we can employ?
Well, I'll jump right on that with a quick response, and I'm sure others would say something too. I touched on this before. I think that we have an educational mission to accomplish, which is to help people understand. You know, back in the early language of DSM-3, we used unfortunate wording. We said patients may show manipulative suicide gestures, as if this was willful behavior trying to elicit a response out of somebody else. Now, of course, there's an interpersonal context to every kind of behavior, but this is internal distress. This is an attempt to deal with suffering. And I don't think people understand that. So we have to help people understand and not hate these patients, because there is such a strong tradition. And, you know, these patients walk into treatment settings with a scarlet bee around their necks. I had an emergency room director at my last job who wasn't a psychiatrist, who said, "We can handle any patient. You just don't send me any of those borderlines. We can't stand them." That's very common. It's very common. He was clueless about what was wrong with these patients. And so we need to really help people understand that this is distress, and that these patients, in fact, are doing the best they can. And that includes a lot of painful stuff.
I'd just like to say something about this. I do think it's terribly important, this idea of good prognosis, bad prognosis. I have to say I don't like it at all. Mostly because I think it puts therapists or everyone else in a bad position along with the particular patient. You know, they're seen as this or that very quickly because they've got paranoid symptoms, they're highly narcissistic, which is thought to be malignant by the assessor or something like this. These are people who are thought to have bad prognosis, but I have to say, if you go and look at the evidence for who does well and who does poorly in any of our treatments at the moment, there's almost no evidence to predict who's going to do well and who's going to do badly. And as a result, we've never selected because of our system at all. And it's never surprised me more to see how some patients who, if you really had pushed me, I'd said, well, you know, give it a go, sort of sense was around, and they do really well. And then there are some you think, yeah, you know, the motivation's there, seems fantastic, and actually they don't do that well. You know, so I don't go on this poor and good prognosis, and we've looked at all our data looking for predictors of outcome. We find nothing. In fact, the only thing that we found that slightly indicated a better outcome was one that was contrary to sort of our general clinical experience, which was if you were male, because we have males and females, which is an odd one. Okay, so we didn't really trust it because it didn't fit. So whether it's correct or not, I don't know. So probably not. So I tend not to go with these sorts of things. One final thing just about that is I do think we've looked at some DBT data of a DBT trial that took place in London. And the group that they found it difficult to keep in treatment were the paranoid, narcissistic group. They dropped out. Now, interestingly, that's not the same in our data, that the mentalizing sort of stance approach seems to retain this group in treatment somewhat better. And it may be that the reason for that is that we're less involved in somehow being directive or demanding or coercing in certain ways, but are much more trying to understand their experience and their cognitive functioning at this moment and so on, that they don't feel so threatened by us and so don't drop out, possibly. But that's just an idea.
How important is an MRI in the diagnosis and treatment of borderline personality disorder?
I'd say it's not at all important. That it's only at a stage where it's useful in research and does not have clinical utility at this point.
The only thing I would add is that occasionally it can be useful by identifying things that you wouldn't expect that may account for the disorder. That because you can see, for example, in some atypical forms of temporal lobe epilepsy or some other kinds of biological problems that phenotypically present with patient behavior that have led to a diagnosis of borderline. So it occasionally will help because it catches something that is completely surprising. But if that's not the case, I totally agree with Glenn.
Another question is, and I'm going to expand the question a little bit, to what extent do hormonal fluctuations that occur during times such as menses, puberty, and menopause, how do these affect borderline personality disorder sufferers?
I think that you often see borderline personality disorder patients with just terrible premenstrual distress and affective storms that are much worse at that point in the month. And I've also developed alliances with those patients so that we can understand what it is that's going on right now and know that it is temporary and will pass. Now, I don't know as much about what would happen perimenopausal, because I think we have much less data on women of that age, and as we know from longitudinal data, many patients are much better at that point and would have less of the affective storms. So my main information would be how it can certainly be aggravated at certain points in the menstrual cycle.
The question would be, how is it determined that DBT saved $10,000 per patient in money that would have been diverted to hospital stays? How was this measured?
The study was done by Heidi Hurd, who's a colleague of Linehan's, and as I recall, the way they measured it is comparing that to the control group in terms of usage of hospitalization.
Another question is that I have frequently heard from my trauma history patients that SSRIs make them feel emotionless. Is this an occurrence that one finds in borderline personality?
Yeah, they often call it the apathy syndrome. And it sometimes creates problems with compliance because patients will say, I don't feel like myself. And I'll try to point out to them that toning down the affective storms that they had was the whole point, and that they're actually functioning better in terms of interpersonal relationships, even if they feel somehow muted or toned down. Do you want to say something?
Yeah, but and I think that may well be a help, actually, even though it has to be understood.
Yeah.
But I think sometimes you'll see, I had a patient, for example, who had a combination of borderline pathology and a lot of histrionic pathology. And I treated her a long, long time and started her back in the days when Don Klein and Mike Leibowitz were talking about a condition they called hysteroid dysphoria. And they recommended MAO inhibitors. And I put her on an MAO inhibitor, and she really did better with it. And I treated her for many years, and periodically we would take a drug holiday she would want to try without. Absolutely regular as clockwork. She didn't do well. Mm-hmm. So when the SSRIs came along, she'd read about Prozac and said, could we try this? So I said, that's fine. I think that would be interesting if you want to do that. So we cross-tapered and eventually put her on Prozac. And she absolutely hated it. And she came in close to being in a panic, but for a very interesting reason. She said, you know, I can't stand this medication. I don't feel anything. And as a result, I don't know who I am. And it kicked her identity. Her identity surrounded her emotionality. And so when she lost that, she had a loss of a sense of who she was, and she felt just at sea and couldn't tolerate it. So we took her off, put her back on MAOs, and she did beautifully. Again, case of one.
Here's a question. My experience with borderline personality disorder clients is that there's a large number who have substance abuse issues or dependency, chemical dependency issues. Is this addressed in the empirical research? Is it controlled? And what treatment issues need to be addressed when people have this comorbidity?
Yeah, that's actually something that in the practice guideline that was addressed explicitly, because this is such a common coexisting problem. You don't necessarily, although it's fairly robust, that you will actually have comorbidity, or that is co-occurring diagnoses of substance use disorder and borderline personality disorder. But if you don't reach diagnostic criteria for substance use disorder, you'll also frequently have frequent episodes of substance use. that's a combination. So there's a whole section in the guideline that talks specifically about addressing the substance use problem as something that needs to be specifically focused on. And that can include a lot of techniques that are usually used for addiction treatment itself, including 12-step programs and other things. But it specifically urges the treatment to recognize the importance of the destabilizing nature of that problem and the need to have what's called integrated treatment, which means that you integrate what you're doing for the borderline condition and treatment specifically for the particular substance use that's a problem. Got a flag waving right here.
I think this is a question of clarification, and the question reads, considering Dr. Oldham's slide indicating little change in functional status with treatment, should we revise goals of treatment? Was that the intent of the slide?
Yeah, I think that, again, it will be very clearly the focus of part of the DSM-5 work group to try to understand this and look at it, because I think that the original DBT goals were really focusing on targeted symptoms, which are important, and I think the hierarchy that Glenn showed, no matter which treatment you're using, is still critical, because you've got to start with self-injurious or risky behaviors, and then you also got to work on behaviors that might lead the patient to quit treatment, because then you've lost everything. So those are still at the top of the hierarchy. But I think the notion really otherwise is just as stated, that this is something that's important.
Which comes first, the alcohol or substance abuse intervention or the treatment of the underlying personality disorder?
You know, the which come first question is a tough one in all kinds of arenas. And I don't know the answer to that. The reason I don't know is I think you have to play it by ear and deal with it with every individual patient. I'd be interested in what Anthony and Glenn think. You know, Bob Drake in Dartmouth in New Hampshire has worked with patients of all kinds who have substance use disorders. He focuses on vocational rehabilitation, trying to get patients back to work. And he gave up on the old system, which was that you've got to get them sober before you can put them in the workforce. He turned it around and put them in the workforce and said, you've got to work and then you'll get sober. And it was much more successful. So I think that you have to sort of strategize, but not have a sort of single-minded plan.
Yeah, I mean, certainly in Europe now, the general thing is that if they're clearly interfering with the psychotherapeutic treatment, then they have to be, will be treated in their own right. But they have to be pretty severely interfering. That's partly related to how services are organized, so that substance abuse services will not take people unless they show clear addictive processes, and that the substance use is actually interfering massively with their social function and physical health, for example. So, in fact, you have to be pragmatic and treat patients with borderline personality disorder who are comorbid with alcohol use, substance use. All our patients smoke cannabis. I mean, I can't think of one that doesn't, virtually, to be honest. It's common, and they say, well, I just have a spliff every night. I say, yeah, but that's going to make you a bit depressed, probably. What's a spliff? Oh, sorry, a spliff is our local thing for rolling up your own cannabis into a big sort of cigarette with little twirls on the end. So you do, and they call it a spliff. And they have two at night to help them sleep, of course, or whatever other crazy reason it is. And you have to manage that within the sort of treatment process, basically. So you treat them together.
Another question. A practical concern would be all of your experiences with insurance reimbursement, except for Dr. Bateman, and how does that compare with your experience in England? What are we contrasting with? What are we experiencing here as opposed to that system?
Well, the absolutely just terrible situation we deal with, all of us deal with all the time, and that is it's the same kind of thing that Glenn was talking about. That's true on trying to get people who fund these things or influence these funding decisions. Because if it's not on their political watch or the end of the budget year or before their re-election cycle that you get the results, they're not interested. But it ain't the way science works. And the need for this to, in fact, be longer term. What we see frequently is that we even had the other day an insurance company, HMO, call us at Menninger Clinic and ask if we would hospitalize a patient for 6 weeks, that they wanted to pay for it. And they said that they had just done their math, and they'd already spent an enormous amount on unsuccessful treatment for this patient within the constraints of their usual limits, and they thought that this was not going to help, and they needed a more extensive treatment. But we were astounded, because you never get that kind of call. It's usually the other way around.
Yeah, I think you just have to make the argument based on the cost offset that I was showing in the slides, that ultimately money will be saved, and we do have some data now to back this up. You know, part of the problem is, in my dealings with managed care and insurance companies, they haven't read any of these studies that we talked about today. They will look you in the eye and say, you know there's no treatment for borderline personality disorder. What are you wasting your time for? And I'll say, have you read the literature, and give them references? And, you know, that sometimes can influence them. Or, you know, if this doesn't influence them, then it's don't bother me with the facts, I've made up my mind.
Well, I mean, it's certainly very different in most of Europe, who have much better access to longer-term treatments. And the same applies for borderline personality disorder. The problem we have, well, actually it's a problem you have too, I think, is the accessibility of those services that are more specialized for borderline personality disorder, and they're few and far between. So, you know, it's much harder for some patients, but if you happen to live in the right area, you will get your treatment, and it can go on for as long as that clinician recommends it. So we can, to some extent, hide longer-term treatments within shorter-term treatment systems because of the way the finances are organized and budgeted. We can do it less in the UK than we used to be able to, and we have to justify now longer-term treatments. But usually, if you go and threaten them a little bit, our managers tend to give in, because it's more locally done, so it's more easy to threaten them and say you'll go around their home if they don't agree and things like that. It's a bit harder when they're somewhere else. So we tend to keep pressure in the system. But we're not anywhere like as lucky or as fortunate as Holland, for example. The study in schema-focused therapy was 3 years. Now that's going to be pretty difficult in the UK, to be honest. That's a very long time for us. In Germany, they still have, as in Holland actually, a lot of access to inpatient treatments, to partial hospital treatments, to outpatient treatments, and you can go where you like. In Germany, you can actually go and say, well, I want treatment in Heidelberg, you know, so I can walk around the hillside with the philosophers and so on. That'd be good for me. So you go there, and that is actually paid for and so on. So they have I mean, they're clamping down on it, but we're still, I would say, many years behind your sort of rigorous removal of monies for anything that they can remove it from.
But meantime, I think we have to keep working hard to keep looking to see if we can get results more quickly that can enable us to sort of step the intensity of treatment down in a way that will be better accepted in this country. Martin Bohus in Germany, where they do have this kind of extensive capacity, nonetheless has done a very interesting study looking at DBT on an inpatient basis in a 3-month time window with some pretty good results. It hasn't been a randomized controlled trial, but the data that they are showing are very promising looking. And so the notion of trying to find a way to do it, at least, I don't think we'll find one that will be everything wrapped up tidy and all of it's done in a few months, because I just think that's never going to happen, or it's very unlikely. But I think we can develop a staged treatment strategy that may be able to accomplish a lot with a sort of reduction in intensity and therefore cost over time, or at least I hope so.
I think we have time for 2 more questions, and these aren't easy to answer, but they're interesting questions. And the one that comes to me is, how does the aging process affect borderline personality in general? Is there a natural muting of acting out behaviors due to life circumstances or biochemistry? Does anyone know?
We don't have very good data about that. There are some studies that have looked at borderline prevalence in the geriatric populations, and it is very much there, and probably not adequately seen because it just hasn't been looked for or studied. Now, having said that, there are anecdotal data and clinical impressions that there is a certain amount of what's called mellowing that may occur over time. There are lots of longitudinal studies. So, for example, Joel Paris in Montreal has had now it's over 27 years, follow-along study of patients who were treated intensively in hospital-based treatment. The Menninger psychotherapy study is another longitudinal long-term study. The study at the Psychiatric Institute that Mike Stone has written about, the PI 500, the McLean study, the Chestnut Lodge study, these all have given us longitudinal data. And what some of them would argue is that these patients do better later, which may be misinterpreted as a reduction in symptoms or behavior such as impulsivity and emotional dysregulation. That's what you may think it is. But if you really look at the picture, at least I know Mike Stone would feel that in many cases what you'd find is that these patients have learned how to orchestrate their lives in ways to avoid what gets them out of control. And that leads to a somewhat shallower range of experience in life, but a greater stability. And I think that's a very interesting observation.
Okay, last one. What other personality disorders respond well to DBT and transference-focused psychotherapy? The two disorders I have in mind are antisocial and paranoid disorders.
Anthony has to answer the antisocial.
You were just going to answer the TFP.
Well, we don't have any studies showing that paranoid personality disorder responds to any kind of treatment. And with antisocial personality disorder, there's only one controlled trial, and that was in drug addicts, actually opiate-dependent patients. And if they were depressed, then they responded to expressive supportive therapy, but we don't have data on TFP for that.
There's virtually no data on this in outside the penal system, and the data within the penal system is pretty poor generally for lots of reasons, understandable reasons. But we have done a pilot project with John is about mentalizing an antisocial personality disorder because we thought that it might be one possibility of helping those individuals. And we've done a pilot, and I'll mention it briefly in my talk, but I do think that at the moment we've no idea how to treat this particular personality disorder. And as you showed or John showed, it's a very common personality disorder actually within psychiatric services now, at least within society. And probably we do need to begin looking as to whether it's treatable or not. But certainly we have no data on DBT really, or TFP or any of the other treatments at the moment.
Just my last comment about that. There are good data that demonstrate that antisocial personality disorder creates far more cost and burden to society than schizophrenia. And so if there's one personality disorder where I think we have an enormous need and aren't even remotely close to where we need to be, it's studying that disorder.
One real quick comment. There's very impressive prospective data that genetic vulnerability acted on by childhood adverse environment turns on the gene for antisocial. We have some of the best data here for gene versus environment factors, and if we really wanted to be forward thinking, we would try to get family therapy at, when these kids were very young, if we could identify the genetic vulnerability, to try to get the family to be able to tolerate the kind of temperament these kids have. That might in the long run prevent a great deal of antisocial personality pathology.
And one pick up on that is there are groups that are actually beginning to do that, and there are a number of areas which I think are showing some promise. A group that was in my department in South Carolina, led by Scott Hengler, developed a treatment called multisystemic therapy, or MST, which works with families where an adolescent offender has been apprehended in the correctional system and is still in the family, and there are siblings at risk. And they work in the home with the families in a prevention mode, which is exactly the kind of thing that Glenn's talking about.
All right, we need to stop. I have a few items. Be sure to sign in and out to get your CMEs, your credits, CAs, certificate of attendance,